Hello everyone, welcome to my YouTube channel. So today's topic will be piriformis syndrome and sciatica. Why this topic came into my mind? Because I had a consultations and the patients had already been diagnosed with sciatica. And I told him, how did you know that you have a sciatica? He said he has seen in online and went to a therapist and they have said you have a sciatica. And I just did an assessment. He did not have a sciatica. So he just had a SI joint restriction. So we'll talk about how to diagnose, what are the possible things it can resemble like sciatica. Some other condition can be there and you feel like it's causing sciatica, because unknowingly also they'll think the pain is resembling here and they'll refer to as sciatica. It won't be most of the time. So we'll see how are the things. So these are the treatment wise, these are the diagnosis, and these are the few articles which I have referred for you all. So whenever patient is coming, we cannot just tell them you have this and that. And nowadays all the information are available in internet. They can go and search, and some things will be similar to their condition what they are feeling, and they'll think that it's mimicking that condition, but it won't be that. So how to rule out this? And sometimes whenever you think that sciatic nerve is compressed by the piriformis muscles, no, there is more to it. So we'll talk about today why piriformis syndrome is overdiagnosed. Because whenever the patient is walking into your clinic and they'll have some pain on the buttocks region and radiating down till the thigh, and you'll say that they have sciatica. No, they won't be having that, because nowadays it's more often diagnosed and they'll think that if I have this pain, that means I have sciatica. So the first thing to be considered, this is the first article we are referring to, and this is a multiple structure like your gemellus, obturator, internal complex, hamstring, vascular disorder, or you can say your tuberous band can initiate or compress the sciatic nerve. It's not only the piriformis muscles compressing the sciatic nerve. I know this is the piriformis muscle underneath the sciatic nerve comes. Whenever this muscle is tight, it can compress the nerve. But you have to understand the gluteal fold syndrome. There is a group of muscles. Suppose your gemellus, your obturators, your internal complex, your hamstring, even restriction to your blood flow, like if you have adhesions or scar tissue formation on your buttocks region due to your past injury, so it can also cause that. Even your tuberous band, suppose some alignment in the SI joint has been misaligned, it can cause that pain. Okay, so this is the article from 2016. The second article, now termed as deep gluteal syndrome rather than isolated piriformis syndrome. So this is the article from 2014. What it says that not only the piriformis muscles causes compression to your sciatic nerve, there are more muscles. Suppose the group of muscles of your gluteal region. So whenever those muscles are tight or weak, it can often lead to your sciatic like symptoms, and you cannot always blame the piriformis muscle. Okay, so you have to look into it, what are the things may be causing that issue. Suppose if there's weakness, you have to strengthen that. So all this exercise wise and what are the things treatment wise, I'll teach you in this. We'll talk about that later. So the second article is MRI of 1039 hips were taken and 20% had sciatic nerve anatomy variant, yet no correlations with the piriformis related symptoms. This is the Barrett articles of 2018. So patients with 1039 hips were taken, but only 20% of the people were showing the resemblance of your sciatic, but other rest they were nothing. Even after having a sciatic nerve compression, they did not have any pain. So sometimes not only the structural issue will cause pain, but even your psychosocial, your stress, your anxiety can also cause pain. So there is more to it. So even a gut related issue, whenever you have gut infection, which is misdiagnosed in most of the cases in back pain, we think that it's due to your muscle structure or pain structure. Sometimes it can be your gut issue. You might have some infection inside your stomach. It can cause pain, and that pain can be radiating down. So we call it as a referred pain. Whenever the back pain goes down, it can cause a sciatic like symptoms. So it can mimic the symptoms. It doesn't mean that you have a sciatic. Okay. So the next article is true nerve compression. So how to know if you're having a exactly true nerve compression of a sciatic nerve? So there should be a burning pain, numbness, paresthesia or weakness. That means there has to be a burning, tingling sensation, paresthesia. You won't be able to feel the dermatomes of your legs whenever you're doing an assessment. And there will be a weakness. But most patients report localized dull buttocks pain, not neurological symptom. And you'll see most of the sciatic pain, they'll be complaining more of those on the buttocks region pain. You get it? And they won't show the neurological symptoms like your paresthesia or weakness. So because whenever there is a nerve compression, there will be a weakness around down the chain. Suppose your glutes, your thighs, your hamstring and your calves. So that's how your sciatic nerve runs. So you'll see in some region they'll have a paresthesia. If they are not having that, and most of the thing, what happens, most of the patients report localized dull buttocks pain, but no neurological symptoms. So you have to rule out that also. Other articles, only 6 to 8% of sciatic case are piriformis related. Most of are due to lumbar disc herniation and foramen stenosis. And this is the article from 2008 in Stanford, and this is also very old, because most of the sciatic nerve you're blaming the sciatic or piriformis muscles. It can be due to your disc herniation, and it can be due to your foramen stenosis. That means this is the nerve, then this is the spine. Okay, whenever there's a decrease in the diameter and causing a compression, it can cause pain. And some of the time it's not due to a structural issue. It can be your all the psychosocial issue that is going on in your brain. Okay, all the ego issue you're having, all the relationship issue you're having, all the stress you're having, or the unable to express those feelings. And there are various aspects we see things. After we rule it out, all these things you can know. Sometimes they are thinking that they have pain, but it's exactly nothing is there. It's just that they are trying to hide their guilt or sorrow, their sadness in the form of pain. If you remove the pain from this body, they won't know how to hide their feeling anymore. So they'll see something to catch on. So they'll say, even this pain is gone from my life, I don't know what I'm gonna do. So it can be that also. So there is, we call it TMS, the body mind syndrome. That's a different case, but sometimes it can be due to that also. And last one is your clinical diagnosis. This is the recent article of sciatica, low back pain related. So we'll do the SLR and stuff for this. So later on we'll talk about that. Okay. Next is gonna be a clinical diagnosis pathway. So how to know if the person is suffering from true sciatic nerve compression. Okay. First you have to check for the tingling sensation, burning sensation, shooting, and pain down the leg. That means there will be a tingling sensation, burning sensation down the leg, all the way from the buttocks, your hamstring, your calves, and it to your great toe. It will go right down. Okay, so you have to see that. And second, what you have to see is, first rule out lumbar radiculopathy or referred pain, whether that pain is coming from the lumbar region, the lower back, this region, because we have a fascia, thoracolumbar fascia also is there. Whenever there is a restriction, it can cause pain. And whenever you have to see whether this pain is coming from the lumbar region or exactly from the gluteal region, you have to know that. If the pain is only in this buttocks region, what are the things which you have to consider? You have to consider for lumbar referred pain. The pain from the lumbar region can be referring down. Second, you have to see for the SI joint dysfunction. This is an article from 2018, Lancet cluster. Okay. And yes, the third one, what you have to see is the myofascial pain of deep gluteal pain on the muscle. This is the article from 2008. So this can be due to your myofascial and the deep gluteal muscle tightness or weakness or restriction. So we'll be confirming the myofascial origin. Pain reproduced with stretching or contracting deep gluteal rotators. So in these cases, whenever you tend to stretch the hamstring, they will complain of pain, because that muscles and the nerve is already irritated and inflamed, and whenever you tend to stretch, there will be more pain. What you have to do is, I usually do a decompression. I use more pressure on that area so that the tissue lengthens and more space for the lymph, for the blood and the oxygen to flow, and I focus more on the breathing also. So next, what you have to see is tenderness on palpation. Whenever you touch that area, they'll complain of pain. And you have to always compare bilateral. Don't only do on one side and leave the other side. You have to compare both the side, whether they are showing the same symptoms or same diagnosis. Okay. So what is the mechanism of pain? So mechanism of pain, weak muscles becomes overload. Whenever the muscle is overload, it will tend to tighten. Tighten is always when the muscles is tight, you should remember it's weak. Okay. Either it is in shortened position or in the lengthened position. So this is a new research from 2024. And next, it can generate pain. So whenever the muscle is overloaded, it can tighten. Whenever the muscle is tightened, it can generate pain. So this is a Grimaldi 2011 research. So next, whatever, even what can aggravate more amount of pain, and it can decrease the threshold of tolerating the pain. It can be due to your stress, sleep loss, anxiety, which I've talked about before. Further lower pain threshold, that means whenever these are the conditions, your stress, anxiety and less of sleep, it will make you very sensitive to pain. Whenever you get some simple kind of hurt also, you'll be very sensitive to pain. So this is called psychosocial amplification model. So psychosocial amplification model, whatever it's here, you get it, kinesiophobia we call it. Whenever you do you feel scared to do any activity, it will increase pain because there is no movements in the body. You have to do some movements in your body whenever you're having pain, because what happens over time, due to lack of movements you'll have pain, or due to pain you'll have lack of movement because of the fear. Okay, next will be our evidence-based PT management. I'm not just speaking whatever I want, so I have done a lot of research on this. So deep gluteal syndrome, what are the things you have to consider? First, we have to consider is assessment and diagnosis, patient's education and load, neural mobilization, stretching and motor controls, functional retraining, and adjustive and support the patient. So for under assessment and diagnosis, we'll be talking about, you have to rule out the misdiagnosis, because we are so confident in our diagnosis that we always often misdiagnose. So don't be so confident whenever you're doing so diagnosis also. You have to give chances. There can be other possibilities of having. And we are so much tend like, okay, this patient might have this condition. No, in most of the cases they won't have. You are doing the misdiagnosis. So you need to do a proper diagnosis, whether it is a piriformis or deep gluteal syndrome. Okay, whether there is a true compression of the piriformis muscle which is causing a sciatic nerve compression, or if there is a group of muscles which is causing the sciatic nerve compression, such as your deep gluteal fold syndrome. Next, what you have to do is a functional test. Whenever doing a functional test, check for the hip rotators. Okay, hip rotators, you know, your adductors and all your piriformis muscles and all the other muscles. And next, for your glute strength, see how much strength is there on the glutes. If you don't know, you have to make the patient on the prone lying and do the extension with the hamstring and lower chain glute strength we are doing. And lumbo-pelvic control, whenever they are walking, see whether they have good gluteus muscle stabilization, because due to uneven one side weakness and one side stronger, it can cause other issue or SI joint restriction or gait pattern abnormalities. So this is the Martin 2021 and 2022 research for the assessment and diagnosis. And one more was there in here, clinical diagnosis model for sciatica for low back pain. So these are recent articles. In here we usually check for SLR. We do a straight leg test and we rate the patient into 1, 2 and 3 and 4 according to that. I'll share you this article and all these articles in the link down below. You can just refer to it, okay? Because if I start speaking all those things, it will take, the video will be more longer and you all won't see the longer videos. And this video I'm not making for short term, it's got to be long term. Whenever you feel like you're doing some other things wrong or you're not getting the answer, you can come just look at this video. Maybe you might find something. If not, then it's all well and good. Okay, so second is going to be your pain and educations. Pain education and load. You have to teach the patient about the pain science, how the pain occurs. It's not like only you know the things and they don't know the things. You need to know sometimes pain is very normal. That's the natural response of your body. I'm not feeling well, I'm giving you pain, respond. Okay, so pain overload, weak glutes and neural initiations. So this can be there. And teach pain neuroscience principle. Suppose your graded exposure to like your activity, your sitting and your stairs. So all these things you have to see. You have to teach the patients. If you don't do any kind of activity, there will be a weakness in your muscles and it can lead to your further degradation of the condition instead of improving. So lack of mobility will cause pain. Due to pain, there will be lack of mobility and there will be a fear and you'll have more aggravation of the pain. Regardless of anything, you have to keep on moving. Okay, if the pain is very high, then I'll tell you to take some rest. After that, again, I'll make you move. Because that's the thing you have to do. even no matter whatever painkillers or whatever short-term treatment you do, it's not gonna last. It will be for 1 to 3 weeks. Again, you'll be in the same condition. What's the use? So at the end, we have to strengthen plus mobilize and see what the things is causing you that pain. So now next is going to be your neural mobilization. As you know that we have to glide, okay? Our nervous system is gliding over each other like this. So if you know the slump test, what we do to see the rule out whether you're having any compressions or disc-related issue and stuff, right? So we'll do a sciatic nerve glide and tension relief moves. So these are the glides. I'll show you in the next video how we do the nerve glide to release the pressure from the tissue which is causing the irritation on the sciatic nerve due to inflammations. So next, integrate into functional task improvement, pain-free range of motion. That means whenever you're having any condition, okay, whether you're able to lift your leg little bit, but do it. You don't have to lift it all the way. It's not necessary. But if you're able to lift, regardless of tolerated threshold of pain, you can lift this much, no issue. You can do that, okay? So even check for the functions, whether you're able to walk, whether you're able to sit for 15 minutes and start moving more often. So second will be your strengthening and motor control. This is the main part. Actually, all the main part, but strengthen. You have to strengthen because most of the things, it can be due to your weak muscles. So local, first what you have to do in strengthening and motor control, first local. All your clamshell, hip abductor strengthening, glute bridge, or you can say a little bit of a stretch or planks and stuff. Try to strengthen those cores, all the lower limb and upper body also. And functionals, what you have to do, you have to make them step ups, do the squats, do the hip thrust, little bit of weight lifting, weight shift, all these things you have to do, okay? Weight transfer, little bit of agility movements if they're able to do. So after that, you have to progress to load and symptoms. Whenever you see any condition you're treating, right, whenever you load, they become more stronger. Whenever they are strong, they can tolerate the pain. So they'll have a high threshold of pain tolerance. So make them stronger, not weak. And next is your functional retraining. This is very important. Functional retraining, you have to train the gait retraining, hip lumbar coordinations. You have to train them. Whether if they're limping and walk, you have to teach them how to walk correctly. Your gait pattern, see on that. And you have to take them to do a task or sports specific integrations, whether they are athletes. So you have to go back to your normal day-to-day activity. If you are in the desk job working, you have to do your task related according to your conditions and your profession. So next, last one is your not adjacent supportive. So in adjacent supportive, what you're saying is the supporting all the temporary relief, all your manual mobilizations, your IFT ultrasound and whatever things which you know, your dry knee and all, whichever you do, those are all for temporary. Okay, 1-2 weeks, not more than that. After that, what you have to do is soft release, or you can see your fascia hydration, decompressions, other things, whatever you know, you can do on that. Okay, so these are all temporary release we'll do. And next will be your management, short-term management and long-term management. Whenever you're doing a short-term management, your soft tissue mobilization, fascia decompression, dry needling, hot pack, cold pack, all these things will be there. A little bit of stretching. For long-term, strengthening. There is no other solution I can give you all. You have to go to gym and do strengthening. Okay. And always don't think that if there is structural change in your MRI or X-ray, doesn't mean that you'll have pain. It's not necessary that. And there are so many research now it proves. So you need to know thing of the image also, because don't try to program your exercise program looking at the like your MRI report and stuff. You have to see the person as a whole, individual, see his condition, his weakness, his strength and stuff. Now after that, design the exercise program for them. You'll get a very fast recovery. And I'm planning to make courses for you also. It's gonna be it has taken me for 8 months, so the price will be around very less. I'm charging very less because I want you all to know the things beside all these modalities. If you see most of the patients when I'm treating, I'm not using anything, and it's not necessary that if it's a pain related, it's not necessary you have to take for 1-2 weeks, 3-2 weeks. It just takes only 10 minutes to fix them. You need to know what they're having, come fix them and let go. No need to come session after session, session after session. Not necessary. It's not like that, because Look, I understand if you have a clinic, we need a follow-up to run the clinic. I understand that also. But if you treat the person faster and quicker and better way, you'll get a referrals. You won't get any jobless. You won't never be jobless. You will be referring. Patient will be referring to you. You get it? Do your work properly. Do your things properly. You will be fine. And this is the topic we have to consider. And see you on the next video. Thank you, guys.